It's so good to see so many people joining us. Just want to let you know that the session will begin in just a few more minutes. So good to see you all today. Thanks.
Afternoon, good evening. We will just wait another 30 seconds, see else who will join, and then we'll get going. Thanks. Okay, let's get started. Greetings, my name is Diana Chang Blanc. I work with WHO in the Immunization Vaccines Biologicals Department on the team lead for program strengthening and involved in supporting COVID-19 vaccine introduction. And welcome to the 6th session of our Learning Collective initiative. Next. The topic today is on best practices on integration of COVID-19 vaccination strategies into PHC essential immunization. Next. Next. And because we have multiple languages today, we wanted to just get you set up on the logistical issues first. So you should see at the bottom of your screen an interpretation globe. We will have the first part of the presentation in English. So you may toggle to choosing French or Spanish interpretation. And about halfway through with our second presenter, we will switch to Spanish. So you will perhaps need to go back into the globe and toggle for either English or French. So for those who need this next section in French or Spanish, please go ahead and click on the proper language. Next. Then there's also a live transcript if you would like subtitles as people are speaking. You may see either something at the bottom of your screen that looks like what's on the screen, CC, live transcript, or you may have 3 little dots on the far right of your screen where you will have the option to add captions. And if you click on the captions, then you will be able to see subtitles to facilitate your comprehension. Next. And in terms of the Q&A section, we will have about 2 sessions of Q&A, 10 minutes, 10 minutes. But by all means, you're always welcome to use the chat function to type in any questions. I think you should all be familiar with that. It's the one on the kind of bubble that says chat, and then please use your raise hand function should you want to ask your questions, and that you will have to use your reactions emoji to then raise your hand. Next. The session is being recorded and your attendance is silent assent to be recorded. All the PowerPoints and the recordings will be shared with those who have registered after the call, and a certificate of attendance sponsored by the University of New Mexico will be available via the link in the chat at the end of the session, should you need confirmation of attendance. Next. And just to say that our partner, Project Echo, which is a fantastic partner, collects all the registration, participation, questions, answers, any of the chat comments and poll responses to continue to do data analysis for its Echo programs. Your personally identifiable data will be shared with the project funder. The data may be used in a summation form for reports, maps, communications, surveys, quality assurance, evaluation, and research to inform new initiatives. Next. So welcoming you all again to the Learning Collective Initiative. This may be your 6th session that you've participated in. It may be your first. To say this is something sponsored under the COVID-19 development partnership, where we focus on 34 concerted countries for support. And we've had 6 sessions so far, primarily directed on trying to support national authorities responsible for COVID-19 vaccine introduction. And we provide this platform as a way to facilitate peer-to-peer country learning on the different COVID-19 vaccination experiences. Next. So as I said, this is our 6th session. It's the best practices on integration of COVID-19 vaccination into PHC essential immunization. And we are extremely honored to have 2 colleagues with us, Dr. Boravi from Chai, Cambodia, and Dr. Gladys Benavides Abella from the Ministry of Health of Colombia. And they will speak a little bit more about themselves when they go into their presentations. Next. We will kick off in the next section a bit of a short poll, so we all have a sense of who's on the call right now. Sorry, I was just seeing the interpreter saying that there was a little glitch, but I think we're back on track now for the English-French interpretation. And then after the poll, we'll go into a kind of an introductory presentation by one of my WHO colleagues, Alba Birajelu. But let's kick off the opening poll. We have about 85 people on the call, and this will just take a few minutes. Sachin, you can kick up the poll. And just reminding all the panelists to not touch their screens. You cannot participate in the poll. Those who see the questions in front of you, you will see that the questions are interpreted in both English and Spanish, and we are asking you to just start to answer the questions as you read them. You will have to toggle over the answers to get the full text. So we have nobody yet participating, as far as I can see, one person. But the question is, what do you see as the main benefits for integrating COVID-19 vaccination into immunization programs, primary healthcare? You may choose more than one answer. So you have sustainability, leveraging COVID-19 resources, optimizing vaccination delivery for adults, epidemiological reasons, or other reasons. And you can choose all of those or just one of them. And we'll let this run for another few seconds. Looks like the most common answers are really around leveraging COVID-19 resources, which of course is also linked to sustainability. Okay, yeah, that seems like a stable kind of reply. So really leveraging the COVID-19 resources and sustainability being the primary drivers. thanks. So Sachin, should you show the results, or is this, I see the results, but I'm not sure everybody's seeing the results. Okay, great. So I think we have about, of those that have replied, again, 85% saying leveraging resources, 80% saying sustainability. And the others are on adult vaccination delivery and epidemiologically being strong, but not really the primary drivers. Great, thank you. Can we move to question 2? So question 2 is only one choice. To what extent is your country implementing integration of COVID-19 vaccination into immunization programs? And 1 means no integration, 5 means fully integrated. And we just will see kind of along the scale where the participants fall. Joyce, yes, we will definitely share the meeting recording as well as all the presentations after the meeting. Okay, terrific. Sachin, could you show the results? So we basically have a bell curve where the slightly integrated and somewhat integrated seems to be the peak. And we have about 14% of the respondents saying it's been fully integrated, and about 10% saying no integration at all yet, perhaps. Okay, great. Question 3. Okay, question 3. This is again a multiple choice. So you may answer any or all, or choose any or all. You will have to toggle over the answers to see the full question. So in your country, what are the areas that integration of COVID-19 vaccination is already happening? So for those where it is somewhat or slightly happening or fully integrated, you can tackle this question. Okay, Sachin, I think you can show the results. So we're basically seeing where integration seems to be the most common is around the supply chain and logistics, which I think is not that surprising to people, the demand generation and community engagement, and the co-delivery of the vaccine with other vaccines, with the other options still prominent, but not high drivers. So we have some around with other health interventions at 36%, which is interesting because we'll hear a bit about that from our countries today. Okay, great. 2 more questions left. We'll try to go a little faster. Number 4 is applicable just really to those who may be accessing Gavi funding. So has your country included COVID-19 vaccine integration activities as part of the Gavi CDS application? Okay, I think you can pull up the results, Sachin. So of the 35 or so countries or respondents, about 53% of them say that they have put in an ask for funding support in the Gavi CDS application. So that's good to see that some are optimizing that choice. Poll question 5 is an open-ended question for those who just replied that yes, you have asked for Gavi to support CDS. We're going to ask you to type your answer to question 5 in the chat so that we have a record and we can then keep moving forward. So the question is, if yes, for what types of activities of COVID vaccine integration have you requested Gavi funding? So if you have requested Gavi CDS funding, if you could just type in the chat, which are some of the areas you have functionally requested, then that would be terrific. And we can close the poll. Thank you, Sachin. And we're going to get right now into the content of the presentations. We can click to the next slide. And I'm going to invite my colleague, Alba Bilagelu from WHO IVB to kick off. Thank you.
Thank you so much, Diana. So I work, I'm a technical officer, medical doctor, epidemiologist, and I work as part of Diana's team on how to plan and how to implement integration of COVID vaccination into immunization programs, and also thinking about primary healthcare. Next. I'm going to focus today's presentation in some of the questions that have been arising in conversation with countries in other webinars and other meetings. So maybe it could be good to start what's the current context. And we know that there is still uncertainty, and there are things that we know that we can see on the left of this slide, like the hybrid immunity, infection, or vaccine induced. It's better than either alone. In low coverage settings, older adults tend to have lower seroprevalence than other groups. And that has implications because we know that they are one of the groups that have had an excess mortality, and also they are at higher risk of hospitalization. And we know also that the variant-containing vaccines, those that include also Omicron, have been authorized, but only the mRNA products. And until now, they can be used only as a booster doses, but not for primary series. This is what we know, but what about what we don't know yet? So we don't know what's the evidence yet in terms of duration of protection by the vaccine, and also protection against long COVID. We also have a question about what's the optimum interval between doses. If seroprevalence can be used to modify the vaccine schedules, depending if it's a population with high seroprevalence, or even also if how effective will be the variant-containing vaccines against different outcomes, particularly infection and transmission. And finally, what is going to happen for the future if there is an emergency of other variants, and how the current vaccines will work against them. Next. So in this context, it's where we're talking about integration. And one of the questions that we're hearing is integration to what? Are we meaning when we're saying integration to routine immunization services that we are focusing on vaccinating also children against COVID? Well, I'm going to try to provide some responses to these questions. The first one is that, and I think it was super clear in the poll, in the first question, what are the main reasons for integrating? First one, there is an epidemiological reason, because the most likely future is that there will be waves and periodic boosters probably will be needed, but for high risk groups. I'm not referring to general population. The second one, which is more than 85% of the responses, is sustainability. That move from mass vaccination campaigns that they have been great to be able to reach a lot of people in a short amount of time, but at the same time they have trade-off and they are costly. Leveraging resources, that was also the other response that got more than 80% of the responses in the poll. And thinking not only about immunization programs and PHC, but also thinking how we can better prepare for the next pandemic. And finally, there are some objectives that are mid-long-term, as it is, for example, the life course approach and the fact too, we need to strengthen adult immunization platforms. And this is a great opportunity in alignment with the goals of the Immunization Agenda 2030. Next. And what do we mean by integration? As I said, we got the question many times, like integration to what? So integration has different meanings, and probably we can also use the word mainstreaming as a way to think about what are the low-hanging fruits or how we can use COVID vaccination to strengthen the health system. So WHO and UNICEF, we propose this definition: the partial or full adoption of COVID vaccination into national immunization program services, PHC, and any other relevant health services, with the overall aim of improving program efficiency and sustainability, enhancing demand and improving user satisfaction, also achieving and maintaining satisfactory coverage, and finally addressing inequities. So this is a proposed definition that it's not only about co-delivery, it goes beyond that. Next. And what's the status, the current status of the countries? We know that it's not black or white. It's not that there is a point that you are already integrating. And so it's more like a continuum where there are several opportunities where integration can start to happen. And EMRO, the Eastern Mediterranean Regional Office, the WHO office, they launched a survey in September 2022, so just a month ago, trying to understand what's the current status of 14 countries that they provided responses relating to if COVID vaccine, it's available as part of PHC facility, if it's integrated as part of national immunization program, it's also integrated as part of our REACH activities, and also asking about mass vaccination. And what we can see from the results, it's that in approximately 55% of the cases, it's integrated, so fully integrated as part of the PHC facilities, while where it's really integrated in most of the countries, around 70%, it's the integration with immunization-related services. And we can see also the mapping of the 14 countries in the maps that you can see on the right of the slide. You can see on upper in the slide, those integrated with PHC facilities. And then in the second map, those integrated with EPIs, so the National Immunization Program. So what it's telling us is that integration is happening at different degrees, but it's organically moving towards that direction. Next. In that context, there was a request for WHO and UNICEF, and today I'm speaking on behalf of both organizations, since we created a task team to be able to develop a guidance to provide steps and considerations for countries on how to plan and implement integration. And there are 4 steps that are proposed as part of this guidance. Just to say that this guidance is available in 4 languages, English, French, Spanish, and Portuguese, and it's already available in the link that you can see in the lower part of this slide. So step 1, it's about initiating building on integration. And as part of that step, there are 2 tools that are part of the document that probably could be relevant for countries. The first one, it's a country readiness assessment on integration, which is basically a checklist, yes, no, if no, what it's needed. And then a second tool is there are more than 38 examples of how countries are integrating already COVID vaccination. The idea is that this is not a theoretical exercise. This is based on what is already happening and how different innovations are helping to be able to strengthen the health system. The second piece that I'm going to focus is a step 2, planning and developing a country integration plan. And as part of that, there are A, B, C, D, so 4 pieces that should be considered. The first one is to define a national policy. Who are you going to target in the future for COVID vaccination in 2023, 2024? Who will need a booster? The second one is what other interventions could deliver with COVID vaccination? The seats where this is going to be delivered. It could be a health facility. It could be a combination of many of options with mass vaccination campaigns, or it could be through outreach. And finally, what are the key investments and short-term actions that need to happen for this to be able to be a reality? Next. So in this slide, I'm focusing on A, define a national policy. And this is a summary of the latest WHO recommended schedules for primary series and boosters. And a reminder also that WHO has made clear that either to use homologous schedules, so it means using the same vaccine for primary series and booster doses, it's fine, but it's also fine to do a mix and match, what we call the heterologous schedules. So you can see on the left of this slide, the different vaccines that they do have a WHO SAGE recommendation. They can all be used to complete primary series or for future booster doses, with one exception, because we know that the use of inactivated vaccines to complete primary series or other booster doses, it has shown lower immunogenicity. So that's why there is a preference to use other vaccines as part of an heterologous schedules. I would like to reinforce also the idea that the variant-containing vaccines, the ones that are available right now, they can only be used as booster doses and not yet have been authorized to be used as primary series. Next.
And Alba, I'll need to give you a 1-minute warning.
Okay, thank you. I don't see the slide yet, but what we're saying here is that there is currently no recommendation for booster doses for those that are 12 years old or younger, except if they have an immunocompromising condition. And then co-administration, and this is a question that we're getting again and again. So SAGE has said any vaccine could be co-administrated for adults and adolescents at the same time of COVID vaccine. So that means influenza, yellow fever, it could be also HPV for teenagers. And then the B is also what other interventions could happen at the same time of COVID vaccination. And we're going to hear some experiences today. And we hear from the poll that the co-administration between vaccines, so for example, in Panama, between influenza and then COVID, it's already happening. In Sri Lanka, they are using the childhood vaccination to be able to provide other vaccines and screen the caretakers against COVID. Cambodia, we're going to hear their example today and their pilot, their experience, and then Nigeria doing whole family approach where vaccines are provided depending on your age. Next. And finally, I would like to highlight that this guidance also includes a menu of options on how this COVID vaccine could be delivered. It could be a menu of options between routine mode and campaign mode, and using the innovation that has been happening to be able to identify and reach adult populations. And I'm saying that because the future of COVID vaccination, it's mainly about adult vaccination, focusing on high-risk groups, healthcare workers, elderly, people with chronic diseases and also immunocompromising conditions, and finally, pregnant women. So there is a need to engage with other programs like non-communicable diseases, like HIV, like TB, like also programs that are providing the follow-up for pregnancy to be able to reach all these populations in the future. Next. I'm not seeing the next slide yet, but I can talk about it, which is the last slide. So it's basically reinforcing the idea that while integration initially, one could think that it's about co-delivery with other interventions, this goes beyond that. And we have several examples of how countries are already integrating, for example, in digital data systems, leveraging what they have done for COVID, now for the immunization program, the essential immunization program, or on demand generation and community engagement in Yemen, where they have used midwives to encourage and to provide both COVID vaccination and also essential vaccines, or in supply and cold chain, which has been clear from the poll that it's also happening in the countries participating today in this webinar. And finally, also, there are other ways for planning and financing, like Rwanda, who is planning together what are the domestic resources for COVID as well as for essential immunization program to be able to plan together the future of COVID vaccination. So I'm going to stop my presentation here today because I think we want to hear from countries, and then we can pick up on any questions that you might have. Thank you so much.
Super, thank you, Alba. That was an excellent presentation to set the stage. Can we go to the next slide? So I am very pleased to invite Dr. Boravi from Chai, Cambodia, to discuss the integration with NCD approach in Cambodia, and inviting anybody to, as she is doing her presentation, if you have questions, to type them into the chat, and we can try to address them during the Q&A. So on that, I invite Dr. Boravi.
Okay, thank you, Diana. Do you hear me?
Very well.
Yes, thank you. Good morning, good afternoon, and good evening to everyone. I'm Dr. Boravi L, medical advisor from Chai, Cambodia. In this opportunity, we also have our honor respect Dr. Narat, MCA from Takal Provincial Health Department, joined with us too. Today, on behalf of the Prevention Medicine Department of MOA Cambodia, I would like to share the Cambodian best practice on integration COVID-19 vaccination into immunization program primary health care. Next slide, please. Inside this, we have the six, in the outline, we have 6 points that we will talking about. So the first on overview of Cambodia, COVID-19 vaccination status. Second, describe of pilot intervention. Third, talking about the enable for co-delivery of COVID-19 vaccination without the health intervention. 4, challenging. 5, plan to move from the pilot to the implementation. And the last point, talking key takeaway message. Next slide, please.
Dr. Boravi, we have
Yeah.
some comments that it's a little hard to hear you. So if you could hold the microphone closer
Okay.
to your mouth, that's much
Okay.
better. Thank you. That's great. Thank
Yeah.
you.
Thank you. Okay. The Royal Government of Cambodia, led by the ad hoc committee for the COVID-19, have achieved high vaccination coverage for the primary series in short term for adult and children. The vaccination start from the frontline worker, adult and pregnant women, start from like 18 years old above, and then they start to continue to provide to the children 12 to 17, continue 6 to 11, and then until the 3 years old. The reason for success includes strong government leadership, vaccine availability, communication, education, and also community participation. We can see that the booster dose coverage has slowed down and remain a priority for the government to consider. Next slide, please. The government recognized that the COVID-19 vaccine is the unique opportunity to reach adults with addition utilize hazards, for example, for the NCD screening. With support from the partner, MOA implement a pilot at large vaccination site to integrate NCD screening for adult staff from 40 years old and above when they are coming for a vaccination, COVID vaccination. Later, the pilot was adapted to be delivered during the routine booster dose at health facility. Adjustment made to make the new model for COVID booster delivery and respond to feedback received by the provincial health department and prevention medicine department technical working group. Community health worker VAG in Cambodia were also trained to support education in the commune and continue conduct follow-up activity. The pilot result in 7,500 adults being tested for NCD among 19,000 eligible adults and we found that like 2,700 refer for follow-up case due to they got the abnormal test. During the delivery at the health facility of the booster dose, VAG support was in line and result in 45% people report they are going to get the access care. Next slide. The health worker and patient have had a positive response to the integrated service delivery model, suggest NCD screening integration into COVID-19 vaccine in the future will be well received. It is important to engage local authority to support to encourage wide-scale integrate one COVID-19 vaccine become routine. Impact of participation of the commune village authority will be the greater if formalized and compensate. Ensure availability of resource of testing, education, and financial to ensure safety of healthcare worker and community, and to ensure opportunity for NCD testing are not missing. The other thing is to prevent shortages and ensure adequate capacity and supply through the year. Relating to the capacity building, we have health worker required to be trained to deliver service and to be implement the integrated model. Healthcare worker had limited experience providing NCD service at health facility, include on protocol for provide information and counseling to the patient to encourage early detection and follow-up and treatment. And they also have limited of IEC material for VAG to delivery to their community too. For the data management and reporting should not add burden to the healthcare worker, and it is important for follow-up. Healthcare worker find report to be difficult or time consumer because they are record is not like in place, something like that. Next slide, please. Other hand, we have also about the challenge that we are encountered. In the limit of the provide funding for the NCD community procurement is not yet support yet because of in the decentralized health system, provincial are responsible for health budget and had not yet invest for NCD testing and treatment scale up. This is a plan that being addressed. Pilot had to include fund for community, which was not sustained in the long-term period. This will be addressed with the future government invest under AKIP2 project. We will see in the next slide. Many health facilities were not yet trained to provide NCD care at the time of the pilot. For the data, data show sometimes testing for the NCD was slow due to the healthcare worker priority ambitious COVID vaccine target, because on the time they have the target to provide to reach many people in very short period. That why we see that the testing is less than what we are expecting. Considering for each program target, especially COVID-19 vaccine daily target was necessary, and result is less focused on preventive health screening during the pilot too. No additional funding for village health support group. Result is limited participant because this will be addressed in the future as government revise the VAG model. The VAG are important for mobilizing community to have a seat and require budget to be made available at the provincial level for their participation. With the limited of fund from the national level, VAG support was limited. This will be addressed for the future with adequate budget for the VAG engagement at the provincial level. Next slide, please. What are the plans to move from the pilot to the implementation? The government is making significant investment to strengthen the quality of NCD service in public sector through the AKIP2 project. All health facilities will be trained and also support with procurement, which will pave the way for the future scale up on the integration services. Through significant investment around 115 million co-financed by MOA and World Bank, government plan to implement the health equity and quality improvement project phase 2, AKIP2, which aim to improve health facility readiness and capacity to provide quality NCD treatment in Cambodia. At all operational line, AKIP2 will bear the cost of nationwide training and set up a revolving procurement and supply system for replacing, cleaning, and treatment community, such as offer a launch pad to scale up and integrate service delivery model at a lower cost. COVID-19 vaccine will be the routine immunization and integrate into the other routine service delivery. Looking ahead, MOA plan to routinize COVID vaccine with routine immunization and other primary healthcare service to ensure cost effectiveness and programmatic sustainability, and continue high coverage for COVID-19 will leverage to improve diagnosis and treatment for all essential health service. Cambodia right now is developing a primary healthcare strategy and revise the policy for the community health worker to redefine their role. This will be strengthening PHC service and help scale up integration model. MOA is currently draft the PHC booster strategy. We include prioritization of integrated PHC model of care for public health to ensure all Cambodia are able to access quality service based on a low cost approach. A foundation pillar of the PHC booster strategy is CPP, Community Participate Policy, will define the role and governance of VAG to leverage support for quality healthcare. Partner will also provide support to scale up the NCD COVID vaccine model, as well as exploring integration with other PHC service type, along with the other developing partner, including UNICEF and WHO, plan to support the MOA to scale up and integrate COVID-19 vaccine NCD model of care to additional geographic learning from early lesson and finding from the pilot as part of the continued costing and testing of the low-cost health care approach by MOH. The next slide, please. Here is the last slide from my presentation about the key takeaway. COVID-19 is a good opportunity to reach adults that usually do not access the healthcare service with other utilized service. Government is committed to increase access to all necessary service across the line cost. Thank you for your attention.
That was excellent, Dr. Boravi. Thank you very much. And thank you. You're perfect on time. So we have about 10 minutes left for Q&A. You are welcome to raise your hands if you have a question. I think we can take 2 or 3. But already I see we have 3 questions in the chat. So Dr. Boravi, I will read them, but you can also open your chat to check. So one of the questions was about the PHC menu of services that were being considered with the integration for COVID-19 vaccination. So you spoke about the NCD diagnosis and treatment. Maybe you could speak about what other menu of services were considered. And I would like to add maybe also rejected, maybe things that were thought about, but it was decided not to. So why don't we take that first before we take the next 2?
Can we go to the next 2 first?
Okay, sure. Okay, the next 2. What is the monitoring and supervision mechanism and the AFI surveillance system in Cambodia? If you are able to speak to that, if you can. But overall, the monitoring and supervision of the activities. And the last is what NCD diseases are being targeted to be screened. So you did speak about the blood pressure testing, but are there specific diseases being targeted? Those are the 3 so far.
Yeah, I would like to answer the which NCD disease are target to be screened in the village. Actually, this piloting we have do in 2 province is like in Takao province and in Kampong Chhnang province. We use to do during the COVID-19 vaccine campaign. It's like we do screening on the hypertension and diabetes. So the people the people that have age 40 years or up, they come to get the vaccine. So we encourage them to do the testing on the hypertension, blood pressure, and also glucose, diabetes, for testing for the glucose. Just only 2, not like other disease related to the NCD, just only 2 main disease only for the pilot.
Great. So I think that answered number 1 and 3. Are you comfortable speaking at all to the monitoring and supervision the program has overall, and if possible, AFI monitoring?
Okay. I I will answer about the monitoring and supervision. Actually, this activity is like we have the team from the provincial and the district level. They do the supervision and monitoring for the activity even during the COVID vaccination and also during our piloting. So they have like the checklist to do that, and also maybe they have like the setup for during the campaign. They have to set up this COVID what is called like uh flow for the get the vaccine. So they have to flow for the vaccination. So they have to follow the flow on their time. Maybe I will ask my colleague from the province that they work very closely about the how to do about about the surveillance system, and say that they can help me to answer, or maybe I will give the answer later. It is fine, or we need to answer right now.
No, that's fine. If you,
Yeah.
if you're not the right person to answer, you don't have to answer. But if there are
Yeah.
any Cambodian colleagues on the call, they can also type in the chat if they want to provide any complementary information. So on that note, to be able to stick to time, I'm sure there are more questions people have, but we have to keep moving. Asking anybody to type in any additional questions you have in the chat. And then we're going to move on to the next presentation. And thank you very much, Dr. Baravi. That was
Yeah,
excellent.
thank you. Yeah.
So the next section, we will switch to Spanish. So for those who need interpretation, who are not fluent in Spanish, please go to the globe. And click on the proper language that you need, whether it's English or French. And just reminding people that the presentations will be shared at the end of the session. So on that note, I'm going to invite Dr. Gladys Benavides Abella to get started. Thank you.
Buenos días.
Good morning, everyone. Can you hear me okay?
Perfect.
Muy buenos días para todos.
So good morning, everyone. We are thankful for this invitation for the Ministry of Health in Colombia. Today, I will talk about the COVID pandemic and how we handle the pandemic in our country. Next, please. This is the pandemic in Colombia. Next, please. This is a timeline from the National Plan for Vaccination Against COVID-19 up to date. This, our country starts with exploring the market against new technologies and with everything that was managed in the pandemic. We have different conversations and agreements with a committee that is making decisions and is making recommendations according to, first, acquisition of biologics and what are the more convenient for the country, just to say it like this, and what are the benefits and costs. All different researchers and investigation for introducing this vaccine in our country. We are making an agreement subscriptions with all the experts and different mechanisms, whether they are COVAX and bilateral, because we receive vaccinations through donations too. The country is making a training process for human talent. Approximately 62,000 professionals massively are being trained. Because for us, the pandemic was very new. All these and also the components of the vaccine and application and logistics, delivery, and so on. Also strengthening the chain, the cold chain. Our country is making a very big effort for acquiring refrigerators in Colombia. And we have thermal boxes, syringes, and everything about assets in order to have the optimal service for our population related to COVID-19. Also, we had 1,727 constant points. We always deliver service here. It was a very hard working team and working long days for the immunization in our country in different regions. Our vaccination plan starts with 2 phases and 5 stages. Vaccination is done gradually and during periods, and we started specifically with groups and frontline workers, specifically health assistants, which because they are given all services. This is primary attention and hospitalization. And also we have different resolution, meaning that the country is making decisions on the regulatory actions that were available for all citizens in the country. Everything that was managed and up to date in the vaccination plan is created by regulatory actions. And for us, it was very important, the permanent coordination table. This table is having all allies from the system. And this is according to the development of each one of the countries, like the control and primary attention. And this is for our vaccination plan will be deployed. And also we were having the effect that was needed, that was to vaccinate the population in Colombia. As you all know, we have rural areas. These are very dispersed, and therefore we had a differential vaccination proposal, and we modified stages and levels because of the access and because of the geographical conditions of these territories. And we decided to vaccinate without considering in those territories different stages or different phases. Articulated work with the allies in the system is very important for the system and for the communication strategies, and also to help the population. We know each and every of them, according to the territory, is having a different connotation, and also this is according to the culture. In October, of 2021, we decided to vaccinate kids up to 11 years old, and the country is giving a weekly follow-up through the unified posts that are done weekly, as I mentioned before, with all allies in the system. And we have a 12,000 persons that were gathered from all the country. And also we had a follow-up in municipalities from less than 60%. And also we have a different coordination with the Ministry of Foreign Affairs and the Ministry of Education and all allies in the system in order to be able to reach the population. And currently we are making a conciliation of payments for the COVID vaccine. And also we are starting to include the COVID in the permanent plan for the country next. So the most important actors in this pandemic were vaccinators. We have these images so you're able to understand how difficult this was. This was just a part that we did in the country in order to have access to different places. We're mainly in rural areas, but we did it. Next. This is the vaccination national plan transition with the white phase. So We are having a wide phase for immunization. We are working on the document for implementation of the COVID vaccine. As in order it is coming permanent, we are making different adjustments. We are getting rid of different phases. We are prioritization, and also we are including the COVID vaccine in the UPC for 2023. And also payment of the people that have access to health system. Also, the redistribution rule. And within the plan, the vaccination plan, the delivery is based on need and according to the population. Now we want to give this, we need to define the population groups in order to have this program against COVID-19. Next. This is the basis for the vaccination plan. Phase 1 is to getting ready. Phase 2, operation and integration, and we have management of assets, cold chain management, and pharmacosurveillance. And here, we want to see what are the different levels of the integration plan of the COVID vaccine in the permanent plan. Also, a territorial plan for integration, training in 100% for COVID-19. This is very important for us because I believe this is something that all countries have been faced with. We have very specific groups with human talent, which is very exclusive for the COVID vaccine application currently. We have it included in the permanent plan right now. We are just setting a little details and guidelines to make this inclusion. So we are making a training process. This is a massive process with our vaccinators before the whole inclusion of the COVID-19 biologic procedure in order to move the biologics, because why are we talking about very specific things? Because it made a difference before the movement and availability of the vaccine, as I mentioned before, and also the delivery of the vaccine. It was according to the needs of the territory at the moment that was needed. And also the information report process. And if it is true that we have a system a system which is spy and is giving all tools, however, the process that we lived in the country regarding the pandemic, we are making some improvements. So we are able to have 100% of the information, and also super important to have this tool that is giving information and reports, maps, files, and everything. Now, route for benefits and plans administration companies and programmatic errors and quality failures. Everything has to be incorporated in the immunization plan, have new roles, and what would be the activities when including this vaccination. Now, phase 2, which is integration operation, it starts with training human talent. Communication with the community, vaccination by using tactics and strategies defined by the PIA that is already defined and regulated. Information report, assets, follow-up, induction, and reinduction. What are the different levels that we have right now, which this is the communication plan, the complying of different coverage of territorial vaccination, data report, and inventory update for vaccinations and assets. This is very important, and the PAI is given that too. And also we have operational error and programmatical errors. And then we have phase 3, follow-up for integration. We have the baseline for initial auto assessment. Where are we? Where are we now? Where do we want to go? Follow-up for periodic evaluations for the process advance and for including this new vaccination for our permanent PIA. And what are the levels? This is the application of the vaccination in the PIA program. Next. It's important to mention that currently we have 2,340 points, and approximately 18,000 are having permanent COVID vaccinations, and we are having simultaneous vaccinations. And also we have an advance, but we have identified some points, and we will see all this information reflected. This is difficult access in rural areas and dispersed rural areas. Also, we have problems associated with social conflicts, indigenous population, immigrant population in Bolívar, Magdalena, La Guajira, Atlántico, Nariño, Norte de Santander, and Santander. Those are places that we want to highlight because this is having more presence of immigrants. Lack of human talent continuity within the program, and this is what I just mentioned before because of the different changes that we have regarding exclusive talent. Also, management of the infodemia. This is something that we are working strongly in different territories, and to get rid of this obstacle that in some specific moments have caused different problems. Next. We have only 2 minutes, Dr. Gladys. Thank you. We have vaccination strategies. We have the territorial table to have alliances with different systems. And also we have actions and inputs for the EAPBs, and also to create strategies and alliances, and to have different journals for kids, identify boundaries regarding territory, and to strengthen the communication to reach all the population, intervention for specific places, like hospitals with our adult population and the availability of this vaccination and the booster, and to identify the vaccination for kids for 3 to 11 years old. Next. Those are the vaccination coverage that we have today for COVID. 84.2 for primary and second and only doses, 72% for complete schemes, 43 for the first for primary reforce, and we have 7% in the second reforce. Next. So here, this is where I talked about the download of the vaccination. As I mentioned, in the country, it was about June or August when we started to have a downfall of doses. And that's why we are working in the ministry and different territorial entities. Next. The bars that we show the immigrant population vaccinated, and I'm about to finish here, that we have the population that is having with the primary scheme, but we need to have the secondary for still. For 50 and 60 years, 30 to 49, this is difficult for primary and second boosters because we are working with all allies possible. And we want to make massive journals by intensifying the pregnant population, and therefore all different populations that we haven't reached the expected coverage. Next. We are red according to the coverage that we have reached. This is up to November 8th, and we see the country should be in 72.1, but we still have some departments that are working hard to reach this coverage, and the primary reforce. Green have 40%, which was standardized by the country. Next. And thank you very much.
Great. Thank you so much, Dr. Gladys. I'm just making sure my language is okay. So I invite anybody to actually type any questions in the chat, or raise your hand if you'd like to pose a question to our Colombian colleagues. And while people are thinking of their questions, maybe I could ask one. You had mentioned in the beginning, Dr. Gladys, about collaboration with the Ministry of Foreign Affairs and the Ministry of Education. Could you speak maybe to what type of coordination efforts that required? And then I see Alba has also typed a question into the chat in Spanish. And I don't speak Spanish, but I see los grupos. So I think it's maybe perhaps a similar question. So maybe you could tackle that. Thank you.
Bueno, una de las preguntas del chat.
So one of the questions in the chat says if it's possible to clarify how are we interacting with ministries and services to reach the risk groups. This is one of the questions, is that correct?
Yes.
La interpretación. Entonces,
That is correct. And I will help with the interpretation because Dr. Adriana were asking that you mentioned the Ministry of Foreign Affairs. And also it is okay to know how were you interacting with the ministry regarding financing. And also the question in the chat is specifically related on how are you interacting with other services to reach pregnant women? You have mentioned that before, but mainly elders and chronic disease population. For example, were not transmissible groups and so on. Thank you very much. Okay, so first of all, we are having gatherings with the Ministry of Education. This is where we started. Through them, we were having access and communication in order to reach the target population. In this case, we talked about kids from 3 to 6 years old, approximately, this is the target. And then kids at school age. We are created alliances and we are getting articulated. So through them, in the Ministry of Health and between ministry, we are having this articulation and we can have strategies in different entities in the territory in order to reach the people. With the Ministry of Foreign Affairs, this is for the immigrants population. We are having a high flow of population from Venezuela, which is our neighbor, in order to have the proper intervention and complete the vaccination scheme. We have a census that is available in different territories, and those are different cities in the country that are forming Colombia. So in this way, we are intervening with the vaccination, and also we have massive journals. And talking about pregnant women, we are making a follow-up with all AAPVs, which are companies that are managing health systems, and IPS, which are primary assistants. We are articulating and making a follow-up and having different coverages with them so they know how it is, and also to create strategies that are reaching population for pregnant women, which are very sensitive. They are very sensitive population because being pregnant, we have a vaccination for post-pregnancy also, and we are working at the ministry level, and we have different departments to make this follow-up. And also to have or trying to have the journals, massive journals that are required through the APVs and also the health services partners, the countries having chronic programs. And this is where we have the vaccination strategy. However, we go hand by hand with the PIA. This is permanent and it is important to complete this COVID scheme, and with the partners, we know who is vaccinated and who isn't according to the data reported with the system. And this is how we are working right now. And every day we are trying to strengthen the work we do, because if you are able to see, we need to move forward still. Maybe Dr. Diana is having another question.
No, I think you answered my question very completely, very well, but I would invite anybody else on the call, if you have any questions, to either type in the chat or feel free to raise your hand. And scrolling up, I don't know if Dr. Boravi is still on the call, but I think this is a question that can apply to both Colombia or Cambodia. It's a question about the communication strategies being used around safety-related concerns of COVID-19 vaccination, and linking with the integration agenda, right? So I think the concerns we've heard from some countries is because there's a lot of misinformation about COVID-19 vaccination or fears. Sometimes integrating with something else can negatively affect the other programs. So I don't know if either speaker would like to just respond to that and just share any reflections from the country. So Dr. Boravi, do you want to come in first? And then I'll hand it to Dr. Gladys. Dr. Boravi, yeah, Mike, great, thanks.
Okay. Okay. I just like, actually in Cambodia, we have like massive plan to interact and respond all the concerns related to the COVID-19 through many channels, as a hotline, social media, healthcare worker, community volunteer, also like private sector also involved, like they have the phone, they have the TV company that they provide all the information. All this part, we have like a reason to strongly engage. Also, they have like strongly engage from the local authority to join with us to make it very successful, to provide all information to the people, to make them very confident and trust to get all the service at the health center related to the vaccine. Also, they join our activity for the screening also the same during on that time. And I just want to add, like, because on that time we also like to make it very like more confident to the people to get the service. We also like have trained to the healthcare worker how to provide the information to them. And also we have the VAG, the commune work, VAG also like have a like very short training to them about how to provide the information to the people to get about the service at the during the vaccine, because on that time we do the provide the service without the cost, because we provide it, and so the people come to the health center with get the free service of charge, both of for the hypertension and also blood glucose testing, and everything like we provide with the good information, good result, that to make them very happy to get our service. Even on that time, we also do the like a small survey to get their feedback that they are satisfied what we are doing in during the COVID vaccine. they said that most of them, they say that they are very happy to get the know that they are healthy before they get the vaccine. So they are very, they suggest them that, oh, can we do this, continue to do this for the scale up to the other province, because on that time we have only two province only with a small place, only like one province around 10 places only, so very small if we compare, we see the whole country. But this are so that the people like they are feel like, oh, very satisfied what we are doing. And when we share with the other partner and also the other province, they say that it's the good model that they make the other province say that can we move this activity to my province too. That why we make it very good result. So that why we make the some donor interest in the future to scale up this activity to the other province in the Cambodia.
Great, thank you, Dr. Boravi. So Dr. Gladys, I will just hand it to you for the last reflections. One was the question if you wanted to answer about the communications around COVID-19 vaccination safety or disinformation and making sure it doesn't negatively affect integration. And then there's a question in the chat about if there's any documentation from Colombia on the collaboration with other ministries and how to systematize that. So for example, needing to work with the Ministry of Education for HPV vaccination, and the linkage is there. So any last reflections you might have before we close?
Doctora Gladys, ¿necesita ayuda con la traducción?
Dr. Gladys, do you need help with the translation? Okay, so I'm going to repeat that. As Diana said, those are two questions. First of all, is about adding something else regarding how Colombia is answering to different rumors when we are having misinformation. Misinformation not based on evidence, and that may impact the COVID vaccination demand. This is one. Two would be a comment related to the chat about if you were able to document this way of working with different ministries as an alliance and how to keep this on time in order to reach good vaccination coverages and other services. And also there is a comment saying that it would be interesting to document your experience with immigrants and also see to how in long term you are thinking about the sustainability of the program. Thank you very much. Okay, so thank you, Dr. Alma. So I'm going to answer now. For the first question, through the minister, she is the one having all this process through the media. And talking about misinformation, those are false news because we had a lot of them from different contexts. And from that, we have different communications from the ministry level to the country. Also, we created communication guidelines in the radio, TV, and everything is downloaded to different territories. And I'm talking about 38 districts and departments that is forming the country. And this is how we handle this, because this was having a lot of impact actually with the vaccination process. So this is everything that we managed regarding the infodemia. And talking about our ministries and what we do with this work, we have this articulation process, we have alliances and we have documented what we have worked so far. and how we did with the Ministry of Education, for example, before intervention in different areas. How have we worked with the Ministry of Foreign Affairs, for example? Yes, it is documented the step-by-step and the follow-up that we gave. We have the traceability and the history of what we have worked with them and what we will continue working with them. And 3, experience with immigrants. So obviously, here we have vaccination for everybody within the Colombian territory, regardless of the nationality. Currently, since 2023, this vaccination will be paid. We have different processes like acquiring vaccination for permanent PAI. However, we still have assets to comply with different needs in 2022. This is what we are working with. We are making some forecasts of the susceptible population for getting vaccinated, and adding to that, we want to forecast massive campaigns in order to have a very happy ending on 2022. Basically, this is what we are doing. Thank you very much.
Great. Thank you, Dr. Gladys, and wish you the best of luck and success for these massive campaigns that you still have planned. So we've got 3 minutes left. I am going to just invite people to look at the chat. There are 2 links that have been provided for a very short survey around your experience with these ECHO sessions today and the previous ones. And these are very helpful for us to essentially decide how we move forward with these sessions after we end this series. So really pleading with you to take 2 or 3 minutes just to fill out those links that are in the chat while we close up. And I will just turn to Alba for any kind of wrap up around next steps with respect to the integration agenda.
Thank you so much, Diana. So 2 slides. The first one is just a reminder, and the slides are going to be shared about what are the resources from WHO, UNICEF that are available. So the guidance, a global compendium, which aims to really collect what are the experiences to date, also in integration from countries. There is a slide deck summarizing the latest WHO SAGE recommendations, for now in English and French, expected to be available soon in Spanish too. And we're developing a frequent asked questions on integrating COVID vaccination. Some of the questions were, and responses were provided today. And next, this is the one about next steps or key messages. There are 4 points. The first one is, as countries have, Cambodia and Colombia has shown, it's now the moment to plan for sustainable future of COVID vaccination and to consider how to engage with other relevant programs beyond the national immunization program. For the countries that are eligible and they can use the 3rd window of Gavi support, these funds could be used for integration purposes in 2023. As countries begin to plan and also build in integration, WHO, UNICEF would be ready to be able to provide support at regional, country office, and also headquarters as relevant. And finally, we have to think longer term and also thinking how this COVID vaccination experience can be helpful for the future and to really build and make and have a strong adult vaccination programs. So to move from childhood vaccination to really thinking about an immunization life course approach. So thank you so much.
Great, thank you, Alba. Is there one last slide or no? Yes, thank you. So just to let people know that the next session will be on Tuesday, December 13th, and it's on the COVID-19 vaccination data and monitoring systems. Please remember to register prior to the call. And just in closing, want to really extend the greatest gratitude to the 3 speakers today for excellent presentations. They all either got up very early or stayed up very late to give them, so we're very grateful to them. And all the materials and the recordings will be available publicly on the site you see before you on the screen. So with that, wishing everybody a very good day, good afternoon, and a good evening, and see you again in December. Thank you.